Time for questions. We have time for questions. I can manage my questions, unless they're hard questions, and then I'll field them off to somebody. Yes.
I think your work is really wonderful. I think it reflects what really good clinicians do. I remember when we were developing a treatment for suicidal kids, it was very structured, and the therapists would come back to supervision and say, you know, our kids' problems keep getting in the way of our ability to deliver treatment.
Right.
So,
Yes.
so
Exactly.
yes, that's a real problem.
Yeah.
Thank you.
Thank you.
Thank you for really a very important kind of framework for thinking about what we've been struggling with in the forum. One of the most compelling and inspiring parts of the forum mission is that the work we're doing to promote children's health is to be inclusive, to include children with disabilities. And I'm wondering, given your experiences across the several states, my guess is you've encountered the siloing and the spin-off and the exclusion criteria and so forth. Is there any way that the kind of wisdom that you're generating can be factored into our work here so that that group of children, 10, 15, 20% of our children, depending on what you're calling a disability, that they also get the benefit of the pioneering work you're doing?
Sure. I mean, I think, again, it was said earlier about this notion of silos, this notion of whether we're dealing with juvenile justice population, whether we're dealing with developmental disabilities, whether we're dealing with child welfare. You know, the fact is we have so much in the evidence base that is reinvented for slightly different populations. And when we do this aggregation, code what's happening in treatments, what we're finding over and over, it is a finite set of things that we do, whether they're delivered by a soccer coach or a school teacher or whether they're delivered by a therapist in a clinic. It tends to be the same kinds of things over and over that help folks. And so really what we're looking at is how do we put more interfaces around that knowledge base so that people who encounter kids with any kinds of problems are in a position to make informed action and to be a therapeutic influence on that child's life. And, you know, so we've tried to solve that in some contexts, mostly in mental health contexts, but I think it's, you know, we're trying to exemplify this larger issue, which is we need to get, we need to be talking across literatures, we need to be talking across organizations, we need to be talking across populations of kids, and mostly what we've been all talking about for the last 40 years is roughly the same thing. So it's time to build those translations. Yes?
This will be the last question.
Okay, Tisha Wyla, National Institute on Drug Abuse. Really great presentation, really thought-provoking in a lot of ways. I'm wondering, the focus of your talk today was on how you implement this in a mental health system. My question is, do you have thoughts on how you would generalize this approach to the systems that refer into the mental health system? So the juvenile justice system, the child welfare, how would you take this approach to those systems that are referring into a static a network of treatment providers that may be delivering evidence-based treatments or things that have these elements of evidence that have evidence behind them to varying degrees?
Well, there's a couple of different ways I would think about that. And again, it's all an interface issue. So it depends on the decisions being made. If you're selecting treatment approaches and trying to identify, you know, what are the best ideas we have at the time to get for a given youth, we've built some tools that would allow people to say, okay, this is the, you know, we encounter people like teachers who say, I don't know what the evidence-based treatments are, right? So now you can go in and say, I'm going to punch in this child's characteristics. Here are the programs, here are the practices. Whatever we refer to should look something like this. And we should have a way of knowing, like I showed with the dashboard, we should have a way of knowing, are we getting what we thought we were referring to? And so, you know, in the selection decision that goes on, what we're trying to do is make it more transparent so people can see what it is they should be getting and whether they're getting what they think they should be getting. But the other piece is we have people in non-mental health sectors that have the capacity to behave in a therapeutic manner. And it's not necessarily an outsourcing, right? That everybody, I mean, that's what I said earlier, everybody who comes into contact with children, and again, I really like what Shep said. I mean, that's really what it's all about, is where do we how do we help the people who are around children, whether it's in any system, to act in a way that's likely to help them achieve their maximum potential? And so how do we build an interface for somebody who is, and this is a lot of what Mary Jane's been doing, to get paraprofessionals and non-professionals who interact with children to be able to say, this is something that will help this child feel less depressed, or this is, I need to encourage him to go out and see a friend or do a positive event, and to ask himself, did it make him feel better, and reflect on that, because the evidence base says that's a good idea. How would someone know that? We have to build something that doesn't look like a stack of manuals and may not look like a 2-page guide, right? It may look like something else. But, you know, again, the theme of what I said at the beginning is we've discovered most of those answers, I think, you know, or at least what we've discovered is probably good enough. It's time to start figuring out how to put that in the hands of all those different people.
Thank you.
Thank you.